Welcome back. I'm Nurse Educator Chelsea, and today we're going to be talking about pancreatitis. Pancreatitis occurs when digestive enzymes are activated while still within the pancreas, irritating cells of the pancreas and causing inflammation. For acute pancreatitis, symptoms can include upper abdominal pain that can be worse after eating, nausea and vomiting, fever, abdominal tenderness, and rapid pulse. For chronic pancreatitis, there can also be upper abdominal pain that's worse after eating, steatorrhea or smelly, oily stools, weight loss without trying, and in some cases, diabetes can occur when insulin-producing cells are damaged. Some causes for pancreatitis can include alcohol abuse, gallstones, certain medications, pancreatic cancer, infection, obesity, cystic fibrosis, or pancreatitis can be idiopathic with no cause. Now, there are complications that can be associated with having pancreatitis. Having pancreatitis can trigger systemic infection leading to SIRS. Another complication is acute kidney injury or kidney failure. It can also lead to respiratory compromise that can include pulmonary effusion, atelectasis, or even ARDS. Acute pancreatitis can also make the pancreas vulnerable to infection and bacteria. Pseudocysts can also form. This happens when fluid and debris collect in cyst-like pockets in your pancreas and can also lead to internal bleeding or infection. Malnutrition is also a major concern with pancreatitis. It can cause the pancreas to produce fewer of the enzymes that are needed to break down and process nutrients from food. With pancreatitis, we often check blood work. This can include an amylase level, which elevates over the first 24 hours of acute pancreatitis and then returns to normal over about 3 to 5 days. This level does not indicate the severity of pancreatitis. We will also see an elevated lipase level. This level tends to stay elevated longer than the amylase level. Also associated with pancreatitis is an elevated white blood cell count, which can be an indication of infection. And then we would also be checking electrolytes. So we often see hypocalcemia, hypokalemia, and hypomagnesemia. When insulin-producing cells within the pancreas are compromised, we can also see hyperglycemia. For imaging, often a CT scan will be done to assess for gallstones and to assess the inflammation of the pancreas. Additionally, we can also do an abdominal ultrasound to assess for gallstones and assess for pancreatic fluid collections. Treatment for pancreatitis typically includes symptom management and resting the pancreas. Resting the pancreas means we'll keep a patient NPO, but we will advance the patient to a low-fat diet as soon as we can to avoid malnutrition. Other treatments include pain management, IV fluids, replacing electrolytes, and if a medication was the cause of the acute pancreatitis, then we would also be changing medications. In some cases, an ERCP can be done to remove bile duct obstructions, which are commonly gallstones. If gallstones are also a cause and an ERCP is not an option, they can also consider a cholecystectomy. In some cases, a patient may need pancreas surgery to remove fluid collections or to remove diseased tissue. For chronic pancreatitis, a patient may need to be started on enzyme supplements. And lastly, I'll be discussing nursing interventions with pancreatitis. So pain is a common concern with patients with pancreatitis. So pain control is one of the nursing interventions we need to be concerned about. If a patient does not have adequate pain control, we need to be discussing pain control and medications with the physician. We also need to be continually monitoring for fluid overload and respiratory compromise. It's always a good idea to encourage your patient to use their incentive spirometer. Lastly, it's always important to be educating your patient and their family on diagnosis, plan of care, and pain management goals. Thank you for coming to learn with me today. Please remember to rate, review, and subscribe to get the latest updates on my